All right. So, ladies and gentlemen, let's move to the next session, which is again very important, and it's actually a debate and sort of state of art session. So, in next 1 hour, we will be addressing a very important topic, which is actually starting antiviral therapy in all HBV immune tolerant patients. Currently not recommended, and we have two speakers, and they will be the one speaker will be talking about in favor of treating this difficult group of patients, and the other person will be actually presenting whether these patients should be treated or not. So let me to invite and introduce our panelist and the chairperson for this session. So first chairperson for the session is no one else but our own Professor Altaf Alam. We all know him very well. He's teachers of teachers and a very well mentor for many of us. Professor Altaf Alam, are you with us? Okay, so our next
Yes, I am. Thank you very much.
Thank you very much. So our next chairperson is Professor Badr Fayaz Zubairi. But Professor Badr Fayaz Zubairi is our very well-known, renowned gastroenterologist, and he's a professor in Civil Hospital Karachi. And again, he has contributed a lot in training the people and many residents in the field of gastroenterology. Professor Badr Fayaz Zubairi, are you with us? Okay, so our next, maybe he can join us in between the session. So our next chairperson is Professor Khalid Hamid, and Professor Khalid Hamid is a well-known gastroenterologist, and he works at Hayatabad Medical Complex, Peshawar. Our next chairperson is Brigadier Retired Dr. Shakil Ahmed Mirza, he is a consultant gastroenterologist and ex-HOD of Gastroenterology, Military Hospital, Rawalpindi. So without wasting
Hi
more time,
everyone.
thank you very much, and hi, assalamu alaikum. So, ladies and gentlemen, without wasting much time, let's move to the first talk, and let me to introduce our first speaker. First speaker is Professor Rafael Esteban, and he's a head of internal medicine and liver unit of Hospital University Barcelona, Spain. And Professor Esteban is a very well-renowned clinician as well as researcher, and he has 350 original articles on his behalf published so far in well-renowned peer-reviewed journals so far. He has been the member of almost all prestigious societies of gastroenterology and hepatology. He has served as secretary of the Spanish Association for the Study of Liver Disease. So Professor Esteban will be talking about in favor of starting antiviral therapy in all HBV immune tolerant patients. Professor Rafael Esteban, welcome in our meeting, and now stage is towards you.
Dear friends, I would like to be in Karachi for the meeting, but this horrible virus prevents traveling. So I am connecting from Barcelona. It is my pleasure to be with you today. My task today is to talk about starting antiviral therapy in all HBV immune tolerant patients. You know, this is not currently recommended by guidelines, so my friend Paul Kuo will be very comfortable to support the contra. These are my disclosures. So, in fact, in hepatitis C and HIV infection, treat earlier is better than treat later. Why should it be different in hepatitis B? We have some tools to treat hepatitis B infected patients. Entecavir, tenofovir, and tenofovir alafenamide are oral, 1 pill per day, safe, well tolerated. There are generics, which are affordable from an economical point of view. They do a potent suppression of viral replication with no or minimal resistance. There are no contraindications, and they need a minimal monitoring. So the guidelines recommend treatment for only some patients. So patients over 30 years of age with family history of HCC or extrahepatic manifestations. You can see that all patients share some similarities. They have none or minimal inflammation and fibrosis. They have high levels of HBV DNA and normal ALT levels. Which are the reasons to treat? First, there is evidence of advanced fibrosis in some cases. You can see in this trial that roughly 10% of patients with normal ALT levels present advanced fibrosis on FibroScan. Roughly, with patients with 1 to 2 times the upper limit normal, 20% of them present with advanced fibrosis. So there is not a light situation. The second reason to treat is the risk of HCC. You can observe in this slide that there is a higher risk of HCC and death in untreated immunotolerant patients versus treated immune-active phase chronic hepatitis B. So in the red line, you can observe that those patients, those untreated patients with normal ALT levels present a higher risk of HCC and death compared to patients with chronic hepatitis B being treated. Again, there is another reason in relation to HCC. There is a clonal hepatocyte expansion in patients during the immune tolerant phase, and this is comparable to the clonal expansion in chronic hepatitis B patients. You know that clonal hepatocyte expansion is a risk factor for developing HCC. So this situation begins during the immune tolerant phase. The third reason to treat is that nucleoside-nucleotide drugs induce similar suppression of viral replication than in E antigen positive patients with chronic hepatitis B. Here, there are some studies, one from Henry Chan, the other from Jordan Feld, and patients treated with tenofovir, Truvada, or entecavir plus PEG interferon. They present a high seroconversion, a high HBV DNA suppression. 55 to 80% of patients with immune intolerant, they present an HBV DNA less than 29 international units per ml. The E antigen seroconversion is very similar to patients with chronic hepatitis B. And of course, HBsAg loss is 0, but the same is true for patients with chronic hepatitis B. There is a comparison between tenofovir and TAF in E antigen positive patients with chronic hepatitis B at week 48. And you can observe that HBDNA levels by baseline HBD level, you can observe that there is a difference, 82% with tenofovir versus 82% with TAF. But the number of patients with less than 9 lux is higher in patients with tough. These are studies with nucleoside, nucleotide, and interferon in E antigen-positive immune-tolerant children, which is very important because you can see that with the combination of lamivudine or lamivudine plus interferon, the HBV negative is roughly 78% and 61%. In another study, 74%. So very high HBDNA suppression in those children. And the E seroconversion is very high. It's 22, 39, or 33%. So very high. Even the HBsAg loss is 70, 21, 22%. So again, very high results among those children with immune intolerance treated with nucleoside analogs and interferon. So the fourth reason to treat those patients is that viral suppression is associated with improvement in clinical outcomes and better quality of life. This is a study from Dr. Yunusi showing that the suppression of viral replication is associated with better patient-reported outcomes. Every of the parameters are better for those patients suppressed compared to those viremic patients. So in summary, treat early is better than later. Nucleoside analogs, entecavir and tenofovir, are generics, safe, and no drug resistance. On treatment viral suppression, the current endpoint of nucleoside therapy is achievable in the majority of E antigen positive chronic infection. Viral suppression is associated with better outcome, prevention of cirrhosis, decreased risk of HCC, improvement of quality of life, and prevent HBV transmission.
So moving towards the next presentation, let me to introduce our next speaker. Our next speaker is Professor Paul Koh, and Professor Paul is a professor of medicine, gastroenterology and hepatology at Stanford University of Medical Center. And before joining Stanford University, United States, he served for 21 years as medical director of Liver Transplant Center at Indiana University. He has distinguished himself in the field of hepatitis C therapeutic and has been the principal investigator on multiple international trials. He recently authored the ACG guidelines naming the evaluation of abnormal liver chemistries. He has received multiple awards, including the Distinguished Award of America's Best Doctor, Gastroenterology, Hepatology, awarded in 2003 to 15. He has received Outstanding Young Clinician Award from the Department of Medicine, Indiana University School of Medicine. Professor Paul is a well-renowned clinician and a scholar, and this is our privilege to invite Professor Paul to talk about the cons of starting antiviral therapy in all HBV immune tolerant patients. Professor Paul.
I would like to thank the organizers for inviting me to this wonderful international meeting. Today we're going to have a discussion regarding starting antiviral therapy in all hepatitis B immune tolerant individuals. This is not currently recommended by guidelines. I'm taking the position that we should not be using this practice. So this audience needs no education regarding the prevalence of hepatitis B in the worldwide scope of the problem. Globally, there are 250 million individuals infected worldwide, and again, high prevalence of hepatitis B here in Pakistan, India, Asia, as well as sub-Saharan Africa. Hepatitis B and C together cause greater than 96% of the deaths from viral hepatitis. You can see here data published in Lancet showing that hepatitis B related cirrhosis is really the driver of morbidity and mortality for viral hepatitis, along with hepatitis C. And indeed, greater than 2/3 of all liver cancers worldwide are attributable to viral hepatitis, 40% of these from hepatitis B, with also a significant contribution from viral hepatitis C as well. Moreover, hepatitis B is a carcinogen. Hepatitis B has been designated by the WHO as a carcinogen, and this was shown most vividly in this seminal study published now over 15 years ago by the Taiwanese group that looked at hepatitis B levels and hepatocellular carcinoma in the REVEAL study. And again, here in this graph, you can see on the y-axis the cumulative rate of hepatocellular carcinoma. And what you see is this biologic gradient that occurs with greater than 10 to the 5th copies of hepatitis B, leading to a marked increase in the relative risk of developing hepatocellular carcinoma. And it is this risk that has really driven our therapy guidelines as we try to suppress virus in order to prevent the development of hepatocellular cancer. Again, this data is derived predominantly from hepatitis B e antigen negative subjects. And today's debate is about treatment of immune tolerant individuals. But it's important that we look at the context for our treatment recommendations. And so you can see here, this is the REVEAL data. And I just show you here in the right table here that 85% of the individuals who were enrolled in this particular landmark study were hepatitis B e antigen negative individuals. Moreover, the majority of these individuals, at least 2/3, were above the age of 40. And this is not the group of individuals that we'll be discussing today, that is those who are hepatitis B e antigen positive. And again, we are looking at now the course of hepatitis B infection, and this data here comes from the EASL guidance, which was very helpful in contextualizing hepatitis B infection. So you see here in the first column, chronic hepatitis B e antigen positive infection. And this is the group we're discussing that we need to treat. That is those with a DNA level that's high, ALT level that is low. These were also historically immune tolerant individuals, and these are the individuals who acquire their infection perinatally. They have minimal or no inflammation, and this period can last up to 4 decades or longer before you get an immune activation with rising ALT, lower DNA levels, and subsequently move on to clear e antigen and eventually, hopefully, clear surface antigen as well. So, who are these immune tolerant individuals? They're typically infected at birth. Most are younger than 40 years of age. They have very high viral levels with minimal ALT and AST, as I said. And we are now characterizing these individuals by ALT and AST level. And our AASLD guidance, recently updated in 2018, noted these immune tolerant individuals were characterized by an ALT of 35 for men, 25 for women, rather than using a local laboratory upper limit of normal. Moreover, we rarely do liver biopsies in immune tolerant individuals, but if we do, they typically show no fibrosis and minimal inflammation. So if we're going to treat somebody for hepatitis B, and we treat many individuals who present to us, the goals of therapy are as shown here. And again, for immune tolerant individuals, there's not much here that we can improve upon histologically, because most of these people have very mild histologic disease. You do see serum HBV DNA declines in those who meet standard treatment indications down to undetected, and we can do this also with hepatitis B antigen positive immune tolerant individuals. It's more challenging. There's no ALT to normalize, and seroconversion rates, as I'm going to show you, are not as robust as they are in individuals who meet standard treatment guidance. And again, for hepatitis B antigen positive individuals, I show this flow diagram here at the top here. You start treatment, you reduce DNA, ALT is already normal, you hopefully clear e antigen, you hopefully seroconvert, and ultimately you hopefully move on to hepatitis B surface antigen clearance. And again, these are the milestones for hepatitis B treatment that we just went over. And again, ultimately, we want to be able to clear surface antigen, which is now called a functional cure. Obviously, ideally, you'd love to clear cccDNA. This is very problematic with our current therapies, and there are many groups now studying to try and really clear or have a sterilizing cure of hepatitis B. But for what we have right now with our current treatment tools, clearance of surface antigen is really our ultimate goal, but suppression of HBV DNA is realistically what we achieve at this time. And again, here is a table showing the treatment guidance from around the world, including Asia, Europe, and a couple of US treatment algorithms here. And you can see here, they all share common themes. It is the viral level, the ALT range, that guide our decisions to treat or not treat these individuals. And we factor in also liver biopsy in certain groups. And more recently, we've had more groups or more recommendations to consider biopsy or other forms of fibrosis assessment to consider treating individuals who may not traditionally have been treated. And again, here are the treatment indications for hepatitis B immune tolerant individuals. And you can see here, I'm going to show you several guidance documents here. In the first column is the ASLD. And again, if the ALT is less than 70 for a male, less than 50 for a female, no treatment. However, if they are above the age of 40, if you do a liver biopsy, they have quite a bit of inflammatory activity. If you do a elastography study like a FibroScan, they have F2 fibrosis, then you can certainly consider treatment in these individuals. Apostle, less than 80, no treatment. But again, if a liver biopsy or non-invasive test shows significant fibrosis, then you can consider treatment, particularly if they have a family history of hepatocellular carcinoma. And the European guidelines, again, allow flexibility with an ALT cutoff of 40. And if it's above 40, you can evaluate with elastography or liver biopsy. And again, if there's substantial liver stiffness or fibrosis, or again, if there's a family history of hepatocellular carcinoma, these individuals can be considered for treatment for their hepatitis B. So here are the seroconversion rates that we see with a variety of therapies over time. And these include our therapies that have gone back many decades now, including lamivudine and defovir, which are no longer first-line treatments. But you can see seroconversion after 1 to 5 years of treatment ranges with our nucleoside-nucleotide analogs from 12 to 22%, depending on the treatment. And again, these are relatively low seroconversion rates, but for immune-tolerant individuals, these seroconversion rates are even lower. And again, surface antigen clearance rates remain disappointingly low with our current therapies. You can see here interferon and tenofovir had some higher rate, but still the overall rates are low. And again, in an immune-tolerant individual you treat with a nucleotide or nucleoside analog, these rates are going to be substantially reduced compared to even these already low rates. So again, here is the treatment guidance from the ASLD. And again, this is how we monitor these individuals. ALT less than the upper limit of normal, high DNA level. You monitor these individuals, and these individuals should not currently be treated. Again, if your ALT goes to slightly above the upper limit of normal, we've already discussed you have an avenue to treat these individuals. And obviously, if the ALT is greater than 2 times the upper limit of normal, with the DNA level greater than 20,000, we treat these individuals. So we do have some flexibility already in treating so-called immune-tolerant individuals, but not really those individuals whose ALT levels are below 35 for men and 25 for women. So if you're following in immune-tolerant individuals, one of the things that this REVEAL study showed, even though the hepatitis B antigen-positive cohort wasn't particularly large, was that if you follow these individuals over time, and here you can see here in the REVEAL cohort, over 4 to 5 years, there was actually a high rate, as shown here in blue, of progression to chronic hepatitis. That means that the ALT level went up, the DNA level went down. And so many of these immune-tolerant individuals, if you follow them, they're going to develop clinically chronic hepatitis B, and you can then move forward with treating these individuals. Moreover, fibrosis progression is uncommon in immune-tolerant individuals. This was a study from 2007, looked at 48 paired biopsies over 5 years, and you can see here there was minimal fibrosis, but there were just as many individuals who had fibrosis progression as who had fibrosis regression. And again, we had one large study published about 6 years ago in gastroenterology, and this was a study that looked at these so-called hepatitis B immune-tolerant individuals. And these individuals were randomized to either receive tenofovir emtricitabine or tenofovir disoproxil. These individuals had normal ALT, high viral levels, with a primary endpoint at 3 years of an HBV DNA level less than 69 international units. And what you can see in this study was that there was viral suppression to less than 69 in over half of individuals in the tenofovir arm, slightly higher, 3/4 in the tenofovir emtricitabine arm, but seroconversion rates were extremely low, 4.8% with tenofovir, none in the tenofovir emtricitabine arm. There were excellent viral suppression levels, but again, no surface antigen loss. Happily, our therapies really are quite good, and there was no resistance that was observed. And so this leads to one of the problems in our immune tolerant individuals. What are the barriers to viral cure? So we have a high viral burden, but the real problem is that we have a weak innate immune response. And viral suppression, which we can certainly effectively do nowadays with our current nucleoside-nucleotide analogs, is not the driving force that will allow us to clear surface antigen, clear e antigen. We need restoration of the immune response to really consider treating these individuals for their immune tolerant hepatitis B, to really affect an e antigen clearance, to really allow individuals to clear surface antigen. And so when we look at the efficacy and limitations of our currently available hepatitis B therapies in e antigen positive individuals, certainly we have potent viral suppression, and we can initiate therapy in these individuals, but you're committed to long-term treatment. And really, in e antigen positive with high viral levels, it's really substantially increased duration of treatment. Many countries will not reimburse for this long treatment. And again, you don't have much in the way of hepatocellular damage. We know the nucleoside-nucleotide analogs reverse hepatic fibrosis if present, but most immune-tolerant individuals don't have substantial fibrosis. You can also prevent progression to liver failure, but again, e antigen positive immune-tolerant individuals don't have advanced fibrosis. So those are some of the benefits potentially of treating immune-tolerant individuals, but without treatment, short and medium-term outcomes in this group are really excellent. And again, low rate of e antigen loss and surface antigen loss with or without treatment with our current nucleoside-nucleotide analogs. We know that if you treat somebody who's e antigen negative, and from the REVEAL study where 85% of the cohort was e antigen negative, that there is an excellent reduction in the risk of developing hepatocellular carcinoma and decompensation, particularly if you have advanced fibrosis. However, in those that are immune tolerant, the effect on HCC incidence is unknown. It's presumed if you had a large enough cohort that the incidence would decrease. But again, the risk of cancer in these patients is actually quite low. Again, we've already discussed lifelong or treatment or long duration is going to be required. We've already discussed costs, the side effects we do have to account for because of the duration of therapy. We have better treatments now, but renal and bone disease, amongst other side effects, will have to be accounted for. Happily, one of the prior concerns, which was development of resistance, is really no longer an issue with our current first-line treatments. So I go back to the AASLD guidance on immune-tolerant hepatitis B. AASLD currently recommends against antiviral therapy, though, again, in individuals with a normal ALT, an elevated HBV DNA with a liver biopsy showing significant inflammation or fibrosis, you can proceed with treatment in these individuals. Again, there's flexibility that is woven into our current guidelines, and I think that is the approach that we should be taking with these individuals until we can get more effective therapies. However, in my practice, those who are immune tolerant with a family history of hepatocellular carcinoma, I treat these individuals routinely, regardless of the ALT level, as I think these individuals are at higher risk for developing hepatocellular carcinoma. Again, introduction of additional agents to improve functional cure in these chronic hepatitis B patients is likely going to alter our approach in the future, and we look forward to testing these therapies in our clinics. Again, thanks so much for the opportunity to present at this conference. Thanks again.
So I would like to go back to Professor Rafael after Professor Paul's talk. What do you think after listening from so many evidences from Professor Paul's presentation? So what is your point of view? Should we treat this group of patients? Shouldn't we consider the treatment for this group of patients?
So I tell you, I fully agree with everything Paul Kuo has tell us. So, but again, so the results of the studies in immunotolerance show the same that in chronic hepatitis B. So the E seroconversion is quite rare in chronic hepatitis B. Of course, the disappearance or the clearance of HBsAg is very, very exceptional in both immunotolerant and chronic hepatitis B. So the results are very comparable. And I tell you, a new argument to treat those children or young adults with immunotolerant phase is the transmission rate. They have very high levels of HBV DNA. So when they go to the kindergarten or the school, they can transmit the infection to other guys, to other children. And there is an important way of transmission in many countries. So there is an additional reason to treat those immunotolerant young persons.
Okay, so Professor Paul, any comments? Or you will
So
still
I think
consider the same point of view?
Yeah, so I appreciate Dr. Esteban's point of view that, if you will, what I touched upon was we really want to eliminate hepatitis C worldwide. And to do that, we're going to need to be able to do two things. Number one, suppress the virus, because obviously those who are suppressed aren't going to transmit. Those that but the ultimate goal is, again, to make hopefully hepatitis B treatment not a suppressive therapy, but rather a therapy that leads to increased functional cure rates. Practically speaking, worldwide, to eliminate hepatitis C, I think what Dr. Esteban said is correct, but the cost of treating all these young individuals and suppressing the virus in all of them, ensuring compliance, I think is going to be just a huge challenge logistically to move forward with. Though I completely agree with the goal that Dr. Esteban outlined. And again, my own opinion is that once we gain additional treatments that hopefully can restore the immune response toward hepatitis B, that the surface antigen levels seem to abrogate, then I think treating just like we treat hepatitis C, if you have viremia, you're going to treat. I think ultimately, years from now, that will be our approach. Something also that Dr. Esteban touched upon is that hepatitis B integration, which we used to think occurred mainly in E antigen negative phase, actually occurs quite robustly in the E antigen positive phase as well. And again, moving forward to prevent cancer risk down the road, I think is going to be another important goal, in addition to the fibrosis, the fact that you retard fibrosis, which is not controversial. So my own opinion is right now with our therapies, logistically, it's not feasible to suppress all of these individuals with hepatitis B who are E antigen positive. But as we gain additional treatments, and particularly, hopefully, as we gain therapies that improve immunomodulation, because we have many preliminary data sets with some of the newer DAAs, if you will, for hepatitis B, like the capsid inhibitors, they certainly help improve the viral suppression, but we need to translate these into better hepatitis B surface antigen clearance rates, in my opinion.
Thank you, Professor Paul. So there is a
So
question.
again,
Oh, okay.
let me see. Again, I fully agree with Paul, but the present is not the future. So in the future, we will have probably better drugs than we have now. But now the endpoint is to suppress HBV DNA, and we can only do that with the current drugs. So I fully agree that in the future we will have probably better drugs and we will be able to achieve a functional cure. But this is not the present. The present, we can only suppress HBV DNA. And I think that we should do that in many patients as we can. And second point, we have generics of these drugs and they are affordable. They are very cheap and we can probably afford the majority of patients to treat with them.
Thank you. Professor Rafael Esteban, connecting with your comment, so there is a question from the audience, partly replied by you within your last comment, that if we will start treatment for these immune tolerant patients, then what will be looking for as an endpoint? So coming again to your comment, is suppressing the DNA will be the sufficient target, or we should be actually looking for some other endpoint as well?
So the right endpoint right now is to suppress HBV DNA. We cannot, unfortunately, achieve HBsAg clearance or, of course, suppress CCC DNA. So this is the future. Right now, the endpoint is to suppress HBV DNA.
Okay, thank you. So the second question is again related to the same thing, that do you think that in present or in near future, the treatment for hepatitis B should be considered for everyone, just like hepatitis C? When the PCR is positive, whatever the level is, they should be treated. So are we looking the same thing in the future?
Yes, I think Dr. Esteban and I agree on this, that I think in the future, we're going to be treating people just as Dr. Esteban outlined. And again, I think the challenge we face in many parts of the world is just the expense of the drug. It's somewhat interesting. The generics in some countries are still outside the realm of what some people can afford. So again, if we can get the price of hepatitis B long term, which again is a long duration therapy, it's not like hepatitis C where a finite duration of a pan-genotypic regimen is actually quite inexpensive. This is going to be with a higher cost, but I believe that once we have the additional therapies that Dr. Esteban has outlined, that we will be treating these individuals. Suppression will be always one of the endpoints, but again, we wish to not only clear e antigen, seroconvert, but also create a function and lead to a functional cure.
Thank you. So now I'll move to our chairpersons for their comments and questions for our speakers. So Professor Shakil Mirza is with us. So Professor Shakil Mirza, do you have any question or comment for our speakers?
Yes, thank you very much, Amna. My question is to Rafael. I know that the present that we're achieving is loss of DNA, at least more than 2 log reduction in DNA. But there's a study with the TF where about 75% of response rates, and there's a significant loss of HBsAg and HBe antigen as well. So shouldn't we be moving on? Shouldn't we be upping the standards or raising the bar to e antigen clearance, e antigen negativity and surface antigen clearance, especially if we are talking of winning this argument of starting the treatment in the immune tolerant phase? Professor Rafael Esteban, please.
Question.
Rafael, please unmute yourself. Thank you.
So thank you for this important question. So I think first that the response among children are different than in adult population. And second, if you see the studies, if you look at the studies, the majority of patients who seroconvert was with interferon. So interferon, again, as you all know, they have a double function, so as antivirals and probably enhancing some immune response. So the reason was that the majority of patients who seroconvert was with interferon. And second, children, of course, respond better. They respond in another way than adult population. So this is the reason. Probably if I treat a child, I would like to achieve this seroconversion.
Thank you.
Thank you.
Thank you very much, Professor Shakil and Professor Rafael. So, is Dr. Khalid Hamid is with us? Dr. Khalid, are you with us? Okay, so we have Dr. Javed Farooqi with us. Do you have, sir, any question or comment for our speakers?
It was thank you very much, Dr. Amna. Thanks to Professor Rafael Esteban and Professor Kao. It was really a great session. Just a couple of years ago, there was one thought. In HB antigen negative infection, when the E antigen is negative and it's a low viral load, should we try the antiviral therapy to make the PCR, the H-based antigen loss? Is there a possibility? One step is taken by the natural immunity. H-based antigen is not there, there is low viral load. Should we treat them? Especially when there is some sorts of fibrosis on the liver?
Sure. So I'll take this one. And so what we have seen again from the REVEAL cohort is that the biologic gradient really shows that if the viral level is quite low, less than 2,000 copies, that the outcomes for fibrosis progression and hepatocellular carcinoma, there aren't high rates of either of these complications. Having said that, though, my thresholds for treating are lower. One of the assays that's available to us recently in the US, and I have to say Europe's been way ahead of us, is that we have a quantitative hepatitis B surface antigen. And I reassure myself in some of these individuals, I will quantitate the surface antigen. If it's very, very low, then I believe these are actually true inactive carriers, and I believe that they don't need to be treated. If it's higher, and again, we have, just like you, we struggle with a lot of metabolic syndrome. So we see a lot of these individuals with low ALT levels, low DNA levels, but the ALTs are not normal. I mean, they're 40, 50, they're bouncing along. And some of these individuals, when the surface antigen is higher, I actually go ahead and suppress these individuals, because I think if you have a concomitant disease, a lower ALT is actually better in these individuals. I don't routinely, if the ALT is truly normal, though, less than 15, then in low viral level inactive carriers, I leave these individuals alone. But, I am looking, and my thresholds continue to drop for the number of individuals that I treat. And just as you indicated, sir, that if I have a elastography score that shows significant fibrosis, then I'm also talking to these individuals about treating. In the US, sometimes, though, that's a little bit more problematic. Our guidance says if you have cirrhosis, you treat regardless of the viral level. And so, but our insurance companies and governments don't reimburse routinely for lower levels of scarring. So that can be a problem for us.
So there is a last burning question. Thank you very much, Dr. Farooqi and Dr. Paul. So there's a last burning question, and then we'll have final comments and from Professor Altaf Alam. So the question is related to a female who is immune tolerant and who want to conceive or going for IVF to conceive. What additional advice should we give to these females in terms of treatment? Should we treat them, or should we just observe them? Professor Rafael, can you please unmute yourself?
So this is very easy to answer.
Okay.
So she can become pregnant, and you should do the prophylaxis during the third trimester if HBV DNA is over 10 to the 6th or 10 to the 7th. Otherwise, there is no risk for the child after delivery. And then you have to study the woman after delivery. If she has chronic hepatitis B, you follow on treatment. If she is negative or a very low level of HBV DNA, you stop prophylaxis. So no risk for the child and no risk for the mother.
Thank
Do you agree, Paul?
Yeah, yes, Dr. Esteban, I agree completely with Rafael. I mean, that completely what he said.
Thank you. So now I'll move to Professor Altaf Alam.
Thank you, Amna, and thank you very much, Paul and Rafael. It was wonderful listening to you. Of course, we understand the limitations of the drugs that we have today, and certainly practice changes in the future. And I'll tell you an anecdote here. A patient comes to me, a 20-year-old, immune tolerant, no family history of HCC or cirrhosis, living alone, no risk of transmission to anyone. And he comes to me and I tell him, you do not need treatment. I'll follow you up every 6 months. And he brings up a prescription with treatment written on it by a very senior person, a mentor actually for me. And he asks me, what about this? And I said, what I'm going to tell you now, there are two types of people in hepatology community. Ordinary, like me, practicing physicians who follow the guidelines. And people like Paul and Rafael who make the guidelines. So, you know, they are the Sufi saints of hepatology. And, you know, if they do something which is against the guidelines, they are the people who make the guidelines and they get away with it. But we can't. We are ordinary mortals and we have to understand our situation. So, Paul and Rafael, you are Sufi saints of hepatology, and we understand what you said is right. But for most of the people, one should continue to follow the guidelines. An immune tolerant patient, more than 30 years old, family history of cirrhosis, HCC, and according to EASL guidelines, risk of transmission, like Rafael was mentioning, one should, or with extrahepatic manifestations, one may go for treatment. But future may have something new for us, and we should look forward to better treatment of hepatitis B in future. Thank you very much. Over to you, Amna. Thank you.
Thank you very much. So, ladies and gentlemen, let me to congratulate all speakers, our chairpersons, and again the audience who were listening. Such a good talk. So, PSH, wonderful job, and this was an amazing, useful session. And I think this is a session where the people could actually debate and discuss for hours and hours and hours, and there will be lots of information still to share. So, hoping for a best future for the treatment of patients with hepatitis B with right now who are not getting the treatment, just like hepatitis C, good days might be coming. So thank you very much, Professor Paul, Professor Rafael Epstein, and our chairpersons. Thank you very much. So thank you very much. And so from here, we'll be moving to the next session, which is actually related to hepatocellular carcinoma, a challenging disease in the developing countries. And the session will be moderated by Dr. Fatima and Dr. Mariam. I apologize for your name. So Dr. Mariam Bakar will be moderating the sessions, and now stage is over to you.